Good afternoon, and welcome to Parkinson Place. My name is Susan Belisi. It is my privilege and honor today to welcome Dr. Deeb. Dr. Deeb is a movement disorder specialist and associate professor at UMass. He's also a co-author of the book, Living with Parkinson's Disease. And Dr. Deeb, thank you very much for being with us.
Thank you for having me and for the kind introduction. So I'm going to speak today about a very important topic, but unfortunately sometimes doesn't get discussed in details when we see people in the clinic with Parkinson's symptoms, and that's the neuropsychiatric symptoms. I'm going to tell you what that means. What do you mean by neuropsychiatric symptoms in Parkinson's disease? So I have nothing in terms of conflict of interest with the presentation except the book. So we're going to be discussing today a few things here about these neuropsychiatric symptoms. And as you can see, there are many neuropsychiatric symptoms in Parkinson's disease. There is memory problems we call cognitive impairment. There is mood issues like depression, but also there's anxiety, there's apathy. There are conditions like psychosis, which is hallucinations. There's impulsivity, there's sleep disorders, there's fatigue. So all of these fall under neuropsychiatric symptoms. And in many cases, these can be a bigger problem for people with Parkinson's disease than what we call their motor symptoms of Parkinson's disease. So these are the tremors, the stiffness, the slowness, the falls. Not that these are not important, but in many cases, the neuropsychiatric symptoms can be more of a problem for many people. So when we think, let's start initially with cognitive impairment. So when we think about cognitive impairment, we think about two things. We think about something called dementia. So that's something we refer usually as Parkinson's disease dementia. And then also there is MCI, or mild cognitive impairment. So mild cognitive impairment is this state before developing a dementia. It doesn't always mean that the person would develop a dementia. It's just having these mild cognitive deficits put a person at a higher risk. So the major difference between the two is the severity of the symptoms, and then how much do these symptoms interfere or negatively impact the person's quality of life. So for example, a person who has Parkinson's disease dementia would require assistance in their day-to-day activities, whereas a person with mild cognitive impairment would notice that they're having some difficulties, let's say in remembering, like in short-term memory, or for example, in using a new tool, but then otherwise they're quite independent, they don't need help with their day-to-day activities. So that's the major difference between these two conditions. And as I said initially, having this MCI doesn't always mean a person is going to develop dementia, but puts the person at an increased risk. So it's very important to evaluate that when a person comes to the clinic. And then whenever we see a person in the clinic, we evaluate multiple aspects of thinking. So it's not only memory that we look for. We also look for attention, and that's usually one of the most common things that are affected even early on in people with Parkinson's disease. So developing a problem with attention, which means how long can a person retain a piece of information? So let's say the easiest example of this is remembering a phone number. In people with Parkinson, the attention or how long a person can keep an information in for the short term, it becomes short term. Other things that can be affected is executive function. So these are the planning and learning new things. And then visual spatial. So this might affect driving. And then also, but to a lesser extent, there can be an effect on language. So such as word finding difficulties, making word errors. So all of these are aspects in cognitive domains. And then if some of them or one of them is affected, then the person most likely has something we call mild cognitive impairment, or MCI. And if they're significantly affected, that person will have difficulty living independently because of those symptoms, then in that case, that person is moving towards a diagnosis of dementia. Usually to make that diagnosis, we usually recommend that the person does a full testing called neuropsychological evaluation, and that will allow us to have a more detailed assessment of these different domains. I'm going to show you a series of numbers to show why this is important. And the reason it's very important is that it is really common in people with Parkinson's disease. So 80% of people with Parkinson's disease have cognitive impairment at some point in their disease progression. That doesn't mean that's not everybody, that's 80%, but it doesn't mean to be that it's not early, usually it is later, but it is a very significant number. So it's very important, especially as the disease progresses, to have that evaluated. And then if it's not brought up by your doctor, to bring it up and discuss it. The other thing is the 25% number. The 25% number is that these are, at any one point, 25% of people with Parkinson's disease. So let's say if we take today and then we go and look at everybody with Parkinson's disease in the United States, 25%, so 1 out of every 4, is going to have symptoms of MCI, not dementia, but MCI, which is they would have some difficulties in one or more of those cognitive domains. And the last number I want to show you is the 10 to 20%. The 10 to 20% are people who might have some cognitive difficulties at the time of diagnosis. So the historical wisdom is that in people with Parkinson's disease do not have cognitive difficulties till much later in the disease. But this is not really true. This is more true for dementia. Usually dementia does not happen until much later in the disease. But MCI, which is some cognitive impairment, can happen even at the time of diagnosis. When the person just started having symptoms, a person might also have some problems with attention or some problems with short-term memory. Again, as I said in the beginning, that doesn't mean this person is going to be demented, but it is important to track these things because they can have what we call a prognostic effect. It can help you and your doctor have a better prediction of how Parkinson's disease will progress over time. So what are the risk factors that increase the risk of cognitive impairment? So these are all risk factors. If you have one or more of those, that doesn't mean you're going to have these symptoms. It just puts you at a higher risk compared to another person who doesn't have them. And some of those are stuff you cannot change. So for example, age, the older the person, the higher the risk of having these changes. The more they had Parkinson's disease, which really is linked to age, but the more they had the duration of Parkinson's disease, the more the risk. Being male increases the risk. Having problems with balance increases the risk. Having psychiatric symptoms, mainly depression, increases the risk. Having difficulty with smell or taste is another factor called hyposmia. Having autonomic symptoms, which is getting dizzy when stand up, especially when they are notable. These also increase the risk of having memory problems, and also having what we call vascular diseases. So having high blood pressure, diabetes, smoking, these things also increase the risk of cognitive impairments. And this is the major one, the vascular disease, that the person can adjust these factors with their doctor to make sure that they're not contributing factors anymore. So with all of this, what can we do to treat these symptoms? So the first thing, that if these symptoms are present, there is limited information about what we can do for people who have simply the MCIs. So people who don't have the dementia, but they have some difficulty with cognition. We don't have any approved medication treatments. There was a study using one of the medications called rivastigmine as a patch form, and it improved people's performance, but not their performance on their test, their performance in day-to-day life. So sometimes we use it if these cognitive difficulties are causing a functional impairment. So that person, for example, is needing to put too many reminder stickers at home, for example, to remember things, then we might try this patch to see if that can help. Now, we have more information about people who have dementia and Parkinson's disease, or called Parkinson's disease dementia, or PDD. And there is one medication that has FDA approval, and that's the rivastigmine. This medication is available as a pill, as well as a patch. So it depends on your insurance and also the way you prefer to take a medicine. And the effect on cognition is modest. So it's not a dramatic effect, but it's around 20–30% improvement. There are other agents that we use that have a similar effect, but they don't have an FDA approval, so we use them off-label. And these will be donepezil. This is available only as a pill, but the advantage of this one compared to rivastigmine is that it is once-a-day pill. There's another one called galantamine that's not as commonly used. And then another agent that's very different in terms of how it works in the brain is called memantine. And then sometimes you use it, although many people don't like the side effects associated with it in Parkinson's disease. So these are the medication treatments that we have. As you see, the list is small and there's not a lot of great treatments at this point. The only ones we have cause modest effect, modest benefit. And this one was 15 years ago. This was when it was introduced in the market. So nothing new since that time. So in the face of this limitation, there are some things that you and your doctor can do that don't require medications that can also give some benefits. So there's going to discuss some pearls, certain things that you can consider you and your doctor. One of the most important things is all the way on the right side is to engage in physical activity. And there is good evidence, whether it is from Parkinson's disease, cognitive problems, or in other conditions of cognitive problems, let's say Alzheimer's disease, which is a very different disorder than what we're speaking about, but shares some features, is that we know that engaging in physical activity can delay the onset of these cognitive changes. So this is more reason a person would be encouraged to engage in physical activity. So it doesn't only help with walking and balance, but it does help with cognitive function. So it's very important to engage in physical activity. Also, it's very important to discuss with your doctor if you have any symptoms of depression, because if you have untreated depression, your cognition is going to be affected, and then you would have features of what we call pseudo-dementia. So that means almost dementia or look-alike dementia. So you really don't have dementia, but because the depression is so severe, your brain function is affected, and that's going to give problems with cognition. So it's important to check that out and manage it as needed. Also check for medications that might be giving cognitive impairment. So many medicines that we use regularly, so medications that can help with bladder control, or medications that can help with sleep, or medications that can help with hallucinations, also medications that can help with acting up dreams at night. All of these can worsen cognition, so it's important to review the list. Also, sometimes the medications that we give to treat Parkinson's disease can affect cognition, so it's important to review the list in detail with your doctor. And like anything else, sleeping is important. So if you're not sleeping well for whatever reason, your cognition is going to be affected. So it's important to discuss sleep. In many cases, people don't bring up sleep when they come and see their neurologist, or the neurologist doesn't discuss that with them. But it's a very important factor, as you're going to see, for almost all these conditions. And then it's important to treat orthostatic hypotension, as we saw, or having autonomic symptoms, which is having dizziness when standing up, can affect cognition. So it's important to treat that. If you have sleep apnea, it's also important to treat it. So these are things that are actionable, stuff that can sometimes easy to do, like engaging in physical activity, that can have significant impact on cognitive impairment. Even if it is not, whether dementia or not dementia, that can have a significant positive effect on quality of life. So this is cognitive impairment, and it's really the most dreaded neuropsychiatric symptom. Everybody is afraid of developing this because it can be associated with loss of independence. Now, the other symptom, or the presentation or symptoms that are associated, that are present or can develop in Parkinson's disease, is psychosis. Psychosis is a combination of two things: is hallucinations, which is seeing, hearing, or feeling stuff that are not there, and delusions are having ideas that are not based on reality. So these could be like paranoid ideas. The thing with psychosis is that it can be associated with a significant caregiver strain. So this one, the cognitive impairment, is the most feared with the people affected with Parkinson's disease, but psychosis can have the most impact on people helping people with Parkinson's disease. And then unlike or similar to a cognitive impairment, there is a relationship with how long the person has had Parkinson's disease. So here we're going to see there is a progression in time going from left to right. So left is early in the disease and right is later in the disease. And then you would see here that psychosis, which is represented in this blue, gets more and more notable as the disease progresses. Now, not everyone develops psychosis. It's around 60% of people at some point will develop some of the features. And that doesn't mean that everybody will develop severe psychosis. It's only 10%, around that number, that will develop these severe or more notable psychosis that usually require treatment. Many people, many of these 60%, will have only very simple types of hallucinations that, although they can be annoying, they're not dangerous because they do not cause any damage, any harm to the person's body, and do not also cause any difficulty with them being independent and doing their day-to-day life. And we're going to discuss the different types of psychosis that a person can have. So the milder forms, which are very common, they occur in around 40% of this total 60%. These can be many forms. One is called illusion, which is seeing something as something else. So for example, here we have this abstract painting, and then you can see here a face, for example. So for example, a person with Parkinson might look at a fire hydrant and think is a bag, for example, or a dog, and then look again, and then they will be like, oh yeah, that's a fire hydrant. So this is illusions. Then there's a very common hallucination is presence hallucination. So let's say this is the person with Parkinson, and they feel as if there's a presence on to the side. And they look to the side, there's nobody, just they have a feeling that a person is there, or almost like a shadow is there. Also, that's quite common. Another one is a passage hallucination. So they feel as if somebody or something is passing them on one side or the other. Usually it's the side that where their motor symptoms are worse. So if they have more stiffness or tremor on that right side, for example, usually they will feel the passage on that same side. Another one is something called pareidolia, but that means recognizing human shapes or human faces in inanimate objects. So for example, seeing in these flowers, seeing a face, for example, or a lion. So that is pareidolia. That's another form of minor hallucination. Another one is called palinopsia, which is feeling as if like there's a smudge whenever something moves, rather than like only not seeing it, as if there's a shadow behind it. So a person with Parkinson's will see as if, as you see here in this picture, there is like what the ball is moving. Usually a person will see only the ball, but then a person with having this palinopsia, this minor hallucination, might see almost like a trail of balls behind it. And then the other one is feeling as if they are outside of a person's body, or looking at looking at their body as if they're dead. This is also another minor hallucination. These, in general, are very mild. They're usually not very distressing, usually, and then they don't always need to progress to more severe hallucinations. And these are the most common form of hallucinations that a person with Parkinson might develop. Now, if the hallucinations progress, then they develop into something we call formed visual hallucinations. So this is, in this case, this will be full details of hallucinations. So they will see a person in front of them. And the distinction here, whether these things require treatment or not, is how severely disturbed a person is because of the hallucination. So a person might see a full hallucination in front of them, but they know that it's a hallucination and doesn't really bother them. So in that case, we don't really need to treat that. But if the hallucination becomes scary, so some hallucinations can be scary, or some hallucinations can come very close to the person's body, or the person cannot distinguish if this is a hallucination or not, and they might act on it. So for example, they might chase it, especially in the middle of the night, or for example, call the police. In that case, then that can be a problem, and then this requires treatment. Now, most commonly, the hallucinations are visual, which is people seeing things. And as you can see here, this is the distribution of the different hallucination by type. So the visual is the most common. And then, but you can have auditory, so you can hear stuff. Usually the other ones come with visual. So a person is seeing something and at the same time hearing, or at the same time feeling, or at the same time smelling. And you can see that smelling is the least common hallucination. And as I said, these ones here, the other three, usually come in combination with the visual. It's very unlikely for a person with Parkinson's disease to have their first hallucination to be a sensation, like feeling something crawling under their skin. That's not common. It will be more visual. So for example, they might see insects and then feel the insects on their skin at the same time. So these are the types of hallucinations. And then the other thing, which is usually a more severe form of psychosis, is delusion, which is having a separation from reality, having thoughts that are not based on reality. And there are different types of delusional thoughts. The most common really is persecutory or paranoid, feeling that other people are trying to persecute them or doing something bad to them. Another one also is a jealousy delusion. And a very distressing one is an imposter syndrome delusion. So in this case, the person would think that their caregiver is not their real caregiver, but impersonating their real caregiver, and the real caregiver is somewhere else. So for example, let's say a person with their spouse, and then both of them are in the home. The person with Parkinson's disease would think that their spouse who's there is not really the spouse, but a person acting as the spouse, and the real spouse is somewhere else. And that person then, the person with Parkinson will come to the spouse who he or she thinks is not their spouse, and tell them that you're not my spouse, where is my spouse, where did you do to my spouse, and all of these. So it can be very distressing. These delusions usually always require treatment because they prevent a person from living at home safely. So these always require treatments. And these will be questions that usually we'd ask you when you come to the clinic to see if there is any concerns. And usually, as another reason why we would usually love to have a caregiver at the same time, because they can give us more information about those. Because in these situations, the person with Parkinson's disease is not aware of them, because that's effectively the nature of the disorder. A person is not aware of them. So what can we do in these situations? So there is no cookie cutter answer here. It's not like one approach fits anyone specifically. It has to be tailored for each person's needs. But the most important thing is that in many cases, looking at the medication list can give us some insight and can help decrease these hallucinations and delusions. So for example, similar to the medications that can affect cognition, these same medications can increase the risk of hallucinations, so like bladder medications. So it would be good to reduce or stop these medications if possible. But also Parkinson's medications, in many cases, we have to decrease, as long as decreasing them is not causing a significant worsening of walking or significant worsening of stiffness. It is possible, especially medications that are not carbidopa-levodopa. So if a person is taking, let's say, 3 different medications, one of them is carbidopa-levodopa and 2 other classes of medications, once they start having hallucinations, we usually want to limit these other medications and take them out because they have a higher chance of causing psychosis. So we usually decrease them. Each doctor would usually prefer to do them in a certain way, but usually that is the first step whenever a person has psychosis. And as I said in the beginning, it is not, we don't have to treat every psychosis. If it is mild, like a presence, hallucinations, feeling something on the side, if the person is not bothered, we don't really, it doesn't cause harm by its mere existence. The only FDA-approved treatment as a pill is medication called pimavanserin. Now, pimavanserin got the approval on it's almost an exception basis from the FDA, because there's really not a lot. There was, before pimavanserin, there was no other FDA-approved medication for this condition. So it was based only on one study, which is a bit unusual, and then a short study, so for 6 weeks. Now that it's on the market, hopefully over a few years, we will be capable of knowing more about it, more details about how effective it is. It's effective for some people, not as effective for other people, but we still don't know which people would respond best to pimavanserin. But it is a medication that we have available. There are other agents that we use sometimes. We can use Seroquel, which is orchidapine. This is the medicine that we use almost all the time. The reason we use it all the time, because it's a simple medicine to administer. There's no need to monitor any cardiac function or liver function or blood tests. You use it, and there are very limited side effects usually. But unfortunately, if you look at the studies, it doesn't seem to be very effective. Although clinically, if you look in clinical practice, some people respond quite well to only quetiapine in controlling their psychosis. The medication that seems to have the most quick effect and most robust effect is clozapine, but doesn't have FDA approval at this point, and that's related to how the studies were done. But if looking at clinical experience, the problem with clozapine is that it requires frequent blood monitoring. You have to do it for the first 6 months every week. If you don't do the blood monitoring, you cannot get the medicine. So it can be a problem for some people. And also, it might not be available in all clinics. Not all clinics will be capable of prescribing it because of this observation requirement. But it is quite effective. So this is usually the approach. Now, sometimes if the person has the hallucinations and also has some cognitive problems, then we might try the medications I discussed earlier for cognitive impairment, such as like rivastigmine or donepezil. These are medications that we can use, and they can sometimes help decrease the hallucinations too, in addition to having their modest improvement in cognition. But in general, this is the approach that we would use for psychosis. And again, there's not always an easy solution. Sometimes we have to reduce the control of the motor symptoms. So we might want to lose some control of the balance, or some control over the walking, or some controls over the stiffness, to gain more control over the psychosis. Because the higher the medication, the higher the dose of the medications to treat the motor symptom of Parkinson's disease, so these are like the tremor and the stiffness, the higher there is a higher chance of psychosis as the disease progresses. It's not early in the disease. And then in many cases, we can control the psychosis quite well. And the goal here is to keep the person at home and avoid the requirement for moving to another level of care, let's say a nursing home or other facilities. So the goal from all these treatments is to maintain independence and then home living. Another thing that is a big problem in Parkinson's disease, and it's becoming even a bigger problem right now because of isolation in due to coronavirus, is mood issues, and mainly depression, but all the other ones too. And we're going to go through some of them quickly. So for depression, there are different forms of depression in Parkinson's disease. So there is something called major depression. So these are significant depressive symptoms that affect quality of life and impair daily function. And they occur in around 20% of people with Parkinson's disease. This number might be higher now because of COVID. The other one is minor depression. So these are some symptoms, a smattering of symptoms of depression. So a person feels low energy, they feel low mood, they feel that they have a decrease in their motivation, a decrease in their self-esteem, but not to a point where they have significant impairment in their day-to-day function. We call this minor depression, and that's present in 30% of people with Parkinson. And then the remaining 50% never develop depression symptoms. Now, the good news in Parkinson's disease is that even with major depression, the risk of suicide is lower than in general population. Because as you know, depression can occur without Parkinson's disease. And then people with major depression without Parkinson's disease seem to have a higher risk of suicide than people with Parkinson's disease. We really don't understand the meaning of that or why that's the case. But it can still be quite impairing. Now, what do we do when we have depression? How do we treat that? So the treatment is a combination of multiple things. First of all is to make sure that the motor symptoms are well controlled, because sometimes if the motor symptoms are not well controlled, then mood issues are going to be affected. And then if motor symptoms are well controlled and there's still depression, it is usually recommended to consider a medication therapy. And the reason we recommend a medication therapy is because there is a chemical change in the brain that happens because of Parkinson's disease. So it's not simply a person is reacting to having a Parkinson's disease. It's not simply an adjustment or a grief response, but it is a chemical change in the brain that makes the person more depressed. So the medications that we use will be 3 different classes. Something called SSRIs, and then the one that has the most studies is paroxetine. The SNRIs, and the one also that has the studies in Parkinson's is venlafaxine. But we usually don't only choose these 2 agents, all the SSRIs, so these will be the Prozac-like medications we would use, and then all the SNRIs we will also use. Another class of medication that can be helpful is the TCAs, and the one that was studied in Parkinson's is nortriptyline. This has some benefits. For example, it can help with urine problems, so people who have to go to the bathroom very frequently at night. The only limitation with that, though, is that it can cause cognitive problems. So it has to, that's why it's important to discuss these things with the doctor and decide which medication will be best. Now, people who have severe depression that's not responsive to any of those treatments, then we can consider electroconvulsive therapy. So this is done under anesthesia, and there's an electric shock to the brain, and that seems to help people with Parkinson's disease with very severe depression symptoms. So don't do this for everybody. It's usually people who are very, very depressed and not responding to the treatments. So again, what are some pearls that you can do very easily at your home, and also you can do with your doctor? So again, always check for medications with your doctor. See if there's anything that's causing the depression. Make sure that the motor symptom control is good and your sleep is good. Also check for medical problems, because sometimes depression can be because of a thyroid problem or some other medical disorder. So it's important to check that out. And then also engage in physical activity. But another thing that it has some evidence is using cognitive behavioral therapy. So that's talk therapy, which is engaging with a mental health counselor to help with processing, as well as helping dealing with this, help to deal with the symptoms of depression. Okay, another mood problem that is usually comes hand in hand is anxiety problems. It's almost the same chance. It's around 40% of people with Parkinson's disease can have anxiety. And there are 2 forms of anxiety problems in Parkinson's disease. One comes with what we call the roller coaster ride. So people with Parkinson's disease can have fluctuations. When they take the medicine, sometimes the medicine works, sometimes it doesn't work, or it sometimes stops working in the middle, and they have like this up and down progression of their symptoms through the day, and we call this the roller coaster ride. And commonly, when they're developing the off time, which means that the motor symptom or the Parkinson's medication's effect is decreasing, the anxiety increases. In many cases, that's really the most bothersome symptom. Not much the tremor, for example, coming back, but more the anxiety happening that can be quite disabling. So in this case, the goal here is the treatment of this type of anxiety is to change the Parkinson's medications and then decrease this roller coaster ride. And in this case, there are multiple different approaches that it's very important to discuss with the doctor about the different approaches to decrease this up and down. But sometimes anxiety occurs even without this up and down. In that case, we will treat it like any other anxiety problem that a person can have, whether they have Parkinson's disease or not. And the medications are very similar to the ones we discussed for depression, except for acute treatment. So for example, a person is having a lot of these up and down, and then they have a lot of anxiety on the way down. Sometimes we would recommend that they use benzodiazepines. So these are medications like Valium or Ativan or these types of medications. We use them with caution because, first of all, they can be addictive and the person can become addicted to them. But also they can be sedating, they can make a person fall, and they can worsen cognition. So we usually, if we need to use them, we use them very cautiously and only for a short period of time. Another one that is very important is apathy. So apathy can happen in depression. Apathy means the person has decreased internal motivation to do things. This extreme form of apathy is that the person will sit in one place and not move the whole day unless another person tells them come and move. And that can happen in depression. So if the person is depressed, then their motivation will be low and they will not have significant activities. But it can happen independent of depression and it occurs in around 40% of people with Parkinson's disease. And at this point, we don't have any good treatments specifically developed for apathy, whether in Parkinson's disease or in depression. And usually what we use is a combination of factors of the approaches. So we would use medications to treat depression, although the benefit there is not as good as in treating depression. We sometimes use stimulants that increase energy. But the most effective approach is to replace the internal motivation with an external motivation. So having a cheerleader. That cheerleader could be a spouse, a caregiver, or it could be the physical therapist, or it could be the support group, where a person will develop would be helped to develop a schedule of activities. And that way, it becomes a bit easier to plan the day. So rather than saying, for example, yes, I will do exercise 2 times a week, saying, for example, on Tuesday at 10 a.m., from 10 to 10:30, I'm going to do exercise and put that on a schedule and have that built in as part of the day activities. That seems to work, but usually that has to come from outside. Sometimes the spouse doesn't want to take that role because it creates a lot of tension, as you can imagine. So in many cases, having other family members or other health team members, let's say a physical therapist or a social worker or a person support group, can be helpful in decreasing the effect of apathy on a day-to-day life. The other thing that's very similar or in the same feature is fatigue. So fatigue in people with Parkinson's disease is a very common and disabling symptom. It is usually worse in the afternoon, but as the disease progresses, it can become throughout the day. So usually the worst time for fatigue is between 2-3 p.m. till around 6-7 p.m. And we still don't understand why fatigue happens in Parkinson's disease. And then as a result, the treatments are very generic. So usually the treatments are, see if we can modify or divide the day into active parts and less active parts. So we call this like the energy bank technique, where you know that you have more energy early in the morning, and that way you would do all the activities that require more energy, and then activities that require less energy can be done or later in the afternoon. Another thing would be engaging in physical activity, a moderate physical activity. It can help with fatigue. Now, severe physical activity or intense physical activity can worsen fatigue, so trying to find a balance between the two. Sleeping very well, of course. And then the other thing is sometimes using medications that are stimulating medications, such as methylphenidate, which is used for ADHD, or other medications. These have to be used by looking at other risk factors, because they can increase some heart strain and palpitations, weight problems. So it's important to discuss with the doctor if it is worth the risk to consider those medications. But and even when we use them, that doesn't mean that fatigue is going to go away. For some people, it does help. For others, it does not. And the last thing I want to speak about quickly is the sleep disorders. So the sleep disorders in Parkinson's disease are very common, and they can be of any type. So it's not only the one that everybody knows about, which is REM sleep behavior disorder, this RBD, which is acting up the dreams. The person is asleep and they start fighting, screaming. It's very violent, and can usually the person who takes the brunt of it is their bed partner. But that's the most stereotypic thing in Parkinson's disease. But there are other things that can happen. There's any form of insomnia, which is difficulty falling asleep or staying asleep. Or the opposite of that, excessive sleepiness, even if the person is sleeping well at night. Fragmented sleep, so sleeping very interrupted and multiple times throughout different times of the day. Nightmares without these behaviors. And then another one called restless legs syndrome, where the person has difficulty lying flat and they feel that they need to keep moving and they have to keep moving around, and that can be very disruptive. So what do we do when a person has a sleep problem? First of all, trying to find the reason for the sleep problem. But then certain things that are easy is to develop an exercise regimen of exercising earlier during the day, so before 5 p.m., to help the body go into a certain rhythm. Also, exposing yourself to bright light early in the morning also can help with that. Having a very regular lifestyle, which is like having breakfast at a specific time, lunch at a specific time, dinner at a specific time, and going to bed at a specific time every day can also help decreasing sleeping problems. Controlling medical problems like depression, anxiety, anemia, thyroid problems, looking at medications that might be causing problems with sleep or excessive sleep. And then also, sometimes a person might have fragmented sleep because their medications are wearing off when they're asleep. They're getting stiff or shaky, and that can wake them up. So discussing with your neurologist these symptoms is very important. And also, if the person has to go to the bathroom very frequently, which is another very common symptom in Parkinson's disease, then their sleep is going to be very fragmented. They won't have a deep sleep, and then they're going to have fatigue and sleepiness during the day. So these are all important things to consider with the doctor, as well as to consider always doing exercise. You see, exercise is very important for almost everything in these neuropsychiatric symptoms. Okay, so these are the ones, and these are like, this is a quick overview of these neuropsychiatric symptoms. One more is the impulse control disorders. So these are, especially if a person is taking a medication called dopamine agonist, they can develop impulsivity, which is they have difficulty controlling their behaviors, usually pleasure-seeking behaviors, and this pleasure-seeking behavior can be in multiple forms. It can be sexual, it can be food-related, it can be shopping-related, it can be gambling-related. So many people would lose, for example, all their life savings because of gambling that happens because of impulse control problems and because of usually the side effect of a medication. So it's very important to keep that in mind, especially if you're taking a medication called in the family of dopamine agonists. So that's pramipexole, ropinirole, rotigotine. They can happen anytime. They don't only happen when you started, they can happen many years after you started. And it can be treated if discovered early, if we stop those medications. And if not, then in that case, we have to add other medications. Becomes a little bit more complex, but it's very important to keep that in mind and then also educate the family members, the caregivers, that this is a risk because a person who is going through this might not realize that their behavior is a problem, might not realize that their spending is more than their mean and than their income. And then in that case, they might be in a big problem if not recognized early. So usually when a person is on those medicines, you and your doctor usually would be discussing this every visit and then revisiting if there is any concern for these symptoms. as we mentioned in the beginning, there is me and the two of my colleagues, we published a book that discusses a lot of those symptoms. There is a chapter in that book about neuropsychiatric symptoms with a lot of these pearls that I showed in the presentation are from this book. How does this differ from Lewy body? And this is a good question, and it depends on who you ask, because it is not at this point. It is still not very clear to the community, to the science community, how much and how dementia with Lewy body is different than Parkinson's disease. So both Parkinson's disease dementia and dementia with Lewy bodies fall under a group called Lewy body diseases or Lewy body dementias, because they both have Lewy bodies and the brain, if you look at the brain. And they have very similar features. The hallucinations are there, the fluctuations, the sleepiness, the change in alertness, these are all the same. And the major difference is like technical about like exactly what is in the brain and how it progresses. So again, there are some people in the field who don't believe that there's a difference and it's a spectrum, and others believe that it is two different things, that we should treat them very differently. So it is, I know it's like half an answer, but this is where we are. It is a spectrum, and then some at this point there are certain definitions, and then it is a random definition. If your symptoms of dementia start within a year of the motor symptoms, we call it dementia with Lewy bodies. If it starts many years after, we call it Parkinson's disease dementia. Any tips on redirecting? Yeah, so there's not an exact tip. It really depends on how severe the psychosis is. So if the hallucination is mild and not causing any problem, I wouldn't redirect. But if it might cause injury or harm, then it will be important to redirect. And in that case, the redirection has to be by trying to be with the person in their same point of view. So assuming what they're seeing and trying to help them to navigate with that. It's easier for me to say it than for you to do it. And it is much, much harder. And that's why whenever these things start, it's very important to speak directly with your doctor to see what can be done to help decrease the intensity of the symptoms. And then, is there an advantage in delaying dopamine, levodopa as long as you can? There is no advantage of delaying. Even though these symptoms sometimes can worsen with higher doses of levodopa or dopamine, but you don't gain benefit by delaying it. It doesn't change. It is simply related to how the disease progresses. They even did studies where they gave people large amount of levodopa suddenly, like just to see what happens. And they did not have hallucinations if they did not have them before. So the levodopa itself doesn't cause the hallucination. It just makes it appear when the disease becomes more advanced. So I would not withhold it if you need it. So can exercise reverse symptoms of Parkinson's disease? It does not reverse the symptoms as far as we know right now. It simply can slow down the development of certain symptoms. So it can slow down cognitive impairment by almost 2 years. This is the information we have. So that's why I highly encourage people to do it, but doesn't reverse it. Okay, there's a double question here. What are some recommended medications for frequent bathroom use at night? So there are some medications that can decrease the bladder hyperactivity. That can be helpful for some people that don't cause significant confusion. So that will be a discussion between you and the doctor to decide that. The other one is sometimes Botox in the bladder can help. And sometimes also using a pill that's used for babies or kids that wet their bed can also be helpful because it decreases urine production. And then also there are certain things that a person can do, which is like timing when they go, how much they drink, when they drink, all of these things can help that. And then any natural homeopathic suggestions for sleep. So the most natural one that's easy to get, of course, is melatonin. I don't know other more notable ones that have significant effect. There's not a lot of good ones, especially if a person is having these neuropsychiatric symptoms. So if a person is having hallucinations, if the person is having memory problems, none of the other ones I would use. I would use everything, even natural substances, very carefully. CBD, I sometimes ask my patients to try it to help with their sleep, because it can relax them and then help them be in the mood to sleep. Herbal remedies, there are many different depending on the culture of what herbal remedies you would use, but so it's effectively the stuff that it's stuff that will help you relax. Effectively, any herbal supplement that will help you relax. But I usually recommend check it with your doctor, make sure it's not going to interfere with your medications, because herbal medications, herbal supplements are effectively chemicals at the end. So they are medications, and they can interfere with either the absorption or interfere with the liver and can cause some problems. So I would just be clear with your doctor that you want to use these herbal medicines, and tell them, I want to use that. Is that okay with you? And then you can use it. Then mannitol for PD. So there is some studies being done. It's still early. We'll see if that's going to show us anything. It is still early studies. So we don't have, it's not clinically available right now. It is like, it's part of a study, but not, I would not recommend that you do it right now outside of a study. Please say more about sleep disorders. Okay, the sleep disorders, they like would require a whole hour by itself. It's a lot of stuff there, but I'm not sure exactly what you want. If you want to discuss, like, tell me what do you want me to focus on, because it is a big topic. So I'm assuming anything new on R&D about what topic again? If you can tell me what topic, that would be great. There is some work being done for development, depending on what topic we're speaking about. I can share. I'm not sure if we would share this presentation. It will be available. They're asking about, so you can look at the different names, and we can.
It'll be on our website, parkinsonplace.org.
Okay. Years before, yeah. So you can have So if you have dementia or word finding difficulties years before Parkinson, tremor, and stiffness, that can be for multiple things. So if you have mild word finding problems, so it's not dementia. If you have word finding problems, some memory problems, that's not unusual in Parkinson's disease, even before the tremor happens. So that's one possibility. The other possibility is it could be dementia with Lewy bodies, which is, as we said, there is this debate, how different and the same. But the other thing is that there are multiple other reasons why a person can have cognitive problems. And so it could be because of multiple mini strokes. It could be because of Alzheimer's disease, which is another condition. So it could be many things. So it is important to check that with your doctor. But it can happen for these three reasons. Cognitive changes can happen before movement problems. There is a question for a short period of time, but I'm not sure if this is truncated. Thank you. Let me just take these out. Okay. So Parkinson, we didn't discuss these autonomic symptoms, but Parkinson's disease can make the body temperature be out of whack. So you can be very cold, you can be flushed, you can be warm, you can be fluctuating. So these are not unusual symptoms, but it's important to check with the doctor for other problems like thyroid. So impulse problems can be very severe, and they can be to a point where a person would lose their spouse or lose their savings. So they can progress very quickly and very insidiously. So it's very important to be clear with the doctor, even so recognizing the early changes. So the early changes will be, let's say, rather than buying one scratch ticket a week, buying 10 scratch tickets a week. Or for example, starting to be developing a sweet tooth when you didn't, or having difficulty stopping yourself from buying everything in the store or buying on Amazon more than usual, or starting to solicit prostitutes, which you didn't do before. And so these things can be trigger signs that something is happening. So So the question about if tremors can change over time with requiring less carbidopa, levodopa, that can happen because of the change in the disease. So some people with Parkinson's disease who have tremor, their tremor can decrease over time. And they change from a tremor type of Parkinson's disease to a tremor to a type of Parkinson's disease without tremor. So tramadol can cause hallucinations, but I'm not sure about the brother with bipolar, because sometimes bipolar, if it's not well controlled, can cause hallucinations. So it's not clear. I cannot answer that question very well. So I'm not very updated on studies in the vet population. We know that there are certain exposures to chemicals. And then also traumatic injury doesn't cause Parkinson's disease, but cause Parkinson's symptoms. But I'm not up to date on those, so I'm going to pass that question. So I'm assuming putting your loved one in a nursing home, this is a very tough discussion. There's no single point. It's really at a point where you feel that they're not safe or you are not safe. That will be the time, but there's no easy answer here. This is a good question about Parkinson's symptoms, general aging. And this is why you see a neurologist. That's what we do when we examine you and ask you to tap, and then tell us, like, do the weird things on the physical examination. So is there anything to control sexual impulses without reducing sexual desire altogether? We don't have that magic elixir yet. And so unfortunately, in many cases, they are one and the opposite. So the best way is to really find the reason why there is why the hypersexuality is happening. So is an ICD, an impulse control problem, then treat that rather than treat the hypersexuality itself. It can, but very little. But it can make you slower and stiffer, because the way it works is that it blocks dopamine. So it doesn't block it very severely, and that's why it's safe to take in Parkinson's, but it can, for some people, they're more sensitive, and it can make you drowsier, and then also it can make you stiffer.
We cannot thank you enough. It's information that we need. And like I said to you before, and I've said to you, when you go to a regular neurologist appointment, sometimes you don't have time to get these type of questions answered. So we truly appreciate your time and your knowledge.